This is Impact Healthcare.
Attention. This podcast has been disrupted.
Welcome to another episode of the Dysrupt Healthcare Podcast. It's interesting, if I have any loyal listeners, you'll notice that we changed the Impact Healthcare to Disrupt. And you'll also notice that we spelled disrupt kind of funny. It's got a Y. And the reason why we chose the Y instead of the I is because we're tired of this industry all focusing on themselves, and instead of the why changing and disrupting the way it works today is the right answer. And I've got somebody who was doing something, saw an opportunity to create more disruption, and has grown an amazing business. Heath Potter, please give us an introduction to yourself and your great company.
Yeah, appreciate it, Lester. So I'm doing this live from the Fireside Chat Studios, and that did not get my background changed, so self-promotion there. But yeah, hey, everybody, Heath Potter, Chief Growth Officer for Six Degrees Health, one of the original founding folks of this organization. Happy to be on the show. We started Six Degrees back in 2012. Coming out of the transplant centers of excellence space, that's where I met Scott Ray, also one of the founders of the company. And we saw an opportunity in the RBP world to utilize data and analytics to negotiate something fair and reasonable amongst all parties involved on those disputed claims. And it really has changed the way that RBP has been done. And now our model has continued to evolve, and maybe we'll touch on some of those things today. But it's been a fun ride. I got started in cost-containment back in 2003, so I'm not the youngest kid on the block anymore. It's funny, you think back when you're first getting started, you're like, man, if I just was a little bit older, a little more experienced, now you're like, just push pause. Slow down. Like, we're going over the peak here pretty soon. But
As I'm seeing your beard and my beard having the little gray color in there, right?
yeah.
But Heath, so, disrupt for me was really about the why, and like the why, my parents' story, you see it every day with people not being able to afford to use their insurance coverage. When you think about, reference-based pricing or just changing the way we look at reimbursement, why does this transparent model actually benefit the end consumer, the patient, the person who actually needs the care? Let's start with that and work our way up.
Yeah. So I'm going to give you a long answer to what was a pretty direct question, but someone asked me this question. It was 2 years ago in a think tank group, and they're like, why are you in this space? It's not easy. And I hadn't thought a lot about it. I always kind of figured you just kind of bumbled your way into where you are. But when you get back to my family, my life, my dad had an accident when I was in grad school, just coming into the workforce. He broke his neck, became a quadriplegic. Very fortunate as a family that we had support, but I saw what would happen, and almost happened to us, is it can just ruin your family. The expense that it took to get him out of ICU. He was there for over 4 months, and then years of rehab. And then the cost of care as a quadriplegic for 17 years is unattainable for most families. And I think that in the end is the driver that I carry with me when you keep pushing the envelope in the disruption component of this, is that you see how it helps families. Not only is it saving employer dollars, but those employers are able to use that savings and give back to their employees. So Six Degrees, we run our own RBP plan. And I had an employee tell me that, until she worked for us, she was never able to afford or to get the procedure she needed to properly hear. And how it has changed her life now that she had Six Degrees and the ability for us to do RBP and to make healthcare affordable for a member. And I've had plans, actually CEOs of plans approach me. This is kind of these stories are going everywhere, but that's fine. That's what this podcast is about, right?
Absolutely.
This guy comes running down this beach. We're at this, like a symposium thing. Dan there jumped on my back and was like, I freaking love you, man. And I'm like, who are you? He was like, you know who I am, but we've been on your plan for 2 years now, and you've saved me $12 million. And we have been able to absolutely change the way that our employees function and this plan functions and what we're able to do for everybody involved. And it's things like that that just keep you going. So it all probably started back with some tragedy in our family that gave me the motivation to build this thing. But it's those victories, those employee testimonials that really make a difference. Another good one, if you want to hear it. This one involves
Bring it. Let's go.
bring it. Okay, so we had I live in the Northwest, and one of the groups we have, it's a whole big physical therapy company. And one of the cool things about how 6 Degrees runs is we do a lot of contracting, and that allows us to work with hospital groups, physician groups, physical therapy groups, and they can be on our plan to help their own employees, but in return we can contract with them and put them into what we call Pro Plus. It's our contracted component of the product. So my inspiring baseball player of a son plays probably too much baseball, but plays year round, and had a separated growth plate in his elbow. And so we go to use the physical therapy company that is using our product. And, we're there for months and months and months. And you kind of get to know your physical therapist, feels like family almost. And one day we're driving in, and I was like, I was telling him the story. I go, it's really cool that they're on our health plan. He's like, well, what do you mean? I go, well, they use 6 Degrees for their RBP health plan. He's like, he's 12. So he's sitting there, she's working on him, and he's looking up at her, and he goes, what do you think about your health plan? And I'm in the room. I'm like, oh man, I don't know. I'm ready for this. And this is completely unsolicited. She said, you know what? We moved to this company called 6 Degrees, about 8 months ago, and it's been awesome. And I was like, all right, victory. He's like, you know who my dad is? She's like, you mean Heath? And he's like, yeah. And then anyways, we came full disclosure on that thing. And she's like, it's been great. I've had 0 issues. It's lowered, my contributions, what was going to be her husband was on the plan now. And I said, well, if you know who to talk to, if you ever had any issues. And of course, like the next month, she's like, hey, I actually had an access issue. I'm like, God damn. And I go, I'll take care of it for you. She's like, no, I'm a big girl. I want to try this thing. I want to see if it's what you told me to. Went back the next week, and she's like, I called your patient support team, got me right in, and everything works perfectly. So, it's fun to have people even in your own community using your solution. And so anyways, there you go. And I was proud of my son for not being timid on asking questions. Future chief growth officer for somebody.
I was gonna say, let's sign him up, right? So Heath, so in case we started on chapter 9 and we need to go back in chapter 1, reference-based pricing, RBP, define it in its kindergarten form.
Yeah. So traditional healthcare and claims processing takes a billed charge. That billed charge is very arbitrary. It, depending on city, depending on state, depending on provider, you could have the exact same procedure that are billed $200,000 different. And then traditional networks or carriers are providing a discount to that, let's say 50%. Now, the cool thing or the uncool thing is, as a facility or a provider, that if you can set your own prices, you can also set your own discounts, right? So it's kind of like furniture sales. You can give a 75% discount if you can set the price. So to the consumer, it's like, oh, I'm getting a great deal. I'm getting 50% off. But what they don't recognize is the hidden pricing mechanisms that are happening behind the scenes, and they don't even know what they're paying for when they walk in the door. That it's not like you got a price sheet that you're looking at and be like, hey, I'm going to go to this ER because my procedure, my skull fracture is only going to cost me X, Y, and Z. You're not making that decision. You're just going where the ambulance takes you. So what RBP does is uses a more widely accepted benchmark. It's not always Medicare, but a lot of times we use Medicare as a starting point. And Medicare is designed to be relatively cost neutral, about an 8% margin built into it, if properly managed. I think we can all say that most hospital systems probably aren't properly managing their expenses. But then we use a multiplier to determine what the reimbursement rate would be. So on a facility claim, typically 140% of Medicare, we found that to be relatively widely accepted. Now, whether it's 6 Degrees or another competitor of ours, they're all kind of doing something pretty close. And there'll be folks that will say, hey, we got this super secret magic sauce that we're applying to it. In the end, it's all relatively the same.
So, just to give people a kind of comparison of what happens today, I'm going to use myself. I had a knee surgery. I tore my ACL, my MCL, my PCL. So I was on one of the major carriers. And I think about this. I went to Tampa General Hospital to have my knee surgery. It was $90,000 of billed charges. Who decided that $90,000?
That hospital, I mean, you could have had that same procedure. And we have the ability to look this stuff up. We call it a program called MetaV that is a lot of the analytics that we're using to determine what a fair and reasonable reimbursement would be. But if somebody in the hospital, whoever's running their charge master, their billing practices, and depending on what you gave them for your insurance, that may change exactly how.
Well, and that's where I was going to go with that. So 90,000 was what, the build charge. Let's call that the price no one's ever going to pay, right? To be able to give a discount, the major carrier that starts with an A, now the allowed charge was 45,000. I had a $5,000 expense of my out of pocket. So in insurance worlds, 90 turns into 45, 45 gets split between the insurance, in this case, the employer, and I paid my 5,000. Now, talk to me at a normal knee surgery, approximately what is Medicare, reimbursing for that?
I don't actually know what it would be off the top of my head, but let's say ballpark, I'm going to say 18,000 or something.
Actually, I know the number since I tell the story, so I was going to tell you 18,000 is exactly right. So
I actually pulled that right out of my.
Literally nailed it. Yep. So 18, and you're saying 18 plus a 40% margin is typically widely accepted. So I'm just going to do 50% because I can do math. Right. So that's an extra 9,000 roughly. So that knee surgery, for all intents and purposes, should probably cost between 28 and 31,000 roughly out the door.
Yep.
So
that's where you're paying, if you'd reimburse on an RBP plan about there. So, and that gives you the delta between, your 40 and where you'd be with RBP. And you're usually in a 35 to 42% savings range, ballpark over your current.
So let's ask the question that, we have to ask is, why would that hospital accept that number? If they're getting over this over here, why would they accept this number over here?
There's different levers that you can pull. Now, some of these things, they just slip through the cracks, and it just doesn't get recognized. Other areas would be working with your local employer. You're a community. You've eliminated what I think even hospital systems would agree is not always a great partner in the BUCA space. Also, a lot of the plans that reside in that ecosystem aren't great at paying claims. And when you get somebody into a self-funded environment that is plan dollars now, It's not somebody else's money, even though it is, but now it's their dollars. You're working with a local system. It's a community, and you're getting those claims paid at a full reimbursement at the determined RBP rate in a prompt manner. There's some incentive there for that to take place.
So just pure econ 101, right? Like outside of warm and fuzzy, keep it in the community based, but hey, we're paying you a fair amount, we're paying you promptly, and all of this back and forth hoopla, in that. Why? So if the natural person heard RBP or reference based pricing, 7 out of 10 cringe and are like, oh gosh, this is gonna hurt. Talk about the old models or maybe the 1.0s versus the Heath Potter 6-degree model, and why is that, ooh, this is gonna hurt, not a thing?
No. Okay, a couple things. One, there is a lot of noise being created by the sales folks of, let's say, the traditional Blue Cross, United, Cigna, Aetna world, right? Because this is competition to them. They're not used to having someone playing in their space, and so if you can create disinformation, it makes it more difficult for a person to make a educated decision. So the biggest competition, biggest noise you hear is coming from people that are fearful of something like this getting the hold, right? So once you're past that and you're looking at or Googling, reference-based pricing, this model has been around for a long time. Even before reference-based pricing was reference-based pricing, you had open network or open access type models. And as reference-based pricing began to evolve, the early versions of it were a little more harsh. Now they were effective at saving dollars, but they didn't necessarily, they weren't polished. Let's put it that way. The member experience was not on the forefront of the design. It was about saving plan dollars. And some of it was very legal focused. So you'd reprice to a certain claim amount. And if there was a dispute, it was basically like, hey, you gotta sue us for more money. And that's a tough environment to have a sustainable health plan. You're gonna save the dollars. CFO is gonna love it. HR, not so much. As we were building this company, I kind of alluded to that earlier on in the podcast, was we came out of the transplant centers of excellence space and we're using data and analytics to mitigate the risk of those large claim events. And what we recognized is data and knowledge is very powerful. So in the transplant world, UNOS regulates organ allocation. And as a result, they could require the participating transplant centers to make that data available. So it was one of the very few areas back in 2012 that you could get access to this transparent data. Now, today, that's much more prevalent. What we used with it then was to identify what are the cost drivers, what are the bill charges, what are the quality components of it, come with something that made sense for all parties, the provider, the plan, the member, us as the vendor helping negotiate all these things and come up with a rate. And that would help us get additional people to them. The provider would have, more volume coming through the system. The plan was happy because we just saved them millions of dollars. And so we saw this opportunity for the everyday claim. The thing we didn't have was the knowledge base. There was not this abundance of information available. So we had to figure out how to come about that information so that instead of litigating everything, we could negotiate resolution. And so we put together a research agreement, got access to the data, built an analytic tool we call MetaV, and we're still using that today. Now, it looks and feels way better than it did back in 2012. In fact, today there's a member component to this so that they can use it for navigation and steerage. But that's kind of where we got to, but it allowed us to negotiate to resolve many of these balanced bills without ever having to bring up a legal play. And that makes it sustainable. It also gives us the ability to contract as needed. So different clients, you have different risk tolerances. Some may be more aggressive. They're really looking to save a lot of dollars. Others are looking for that happy medium. Let's do better than we were, but have a really good member experience. And that's where the vast majority of our plans lie is, let's have something sustainable. And so we can contract our way around issues as they come up. And that may come in the form of a global contract. It may come up in the form of a single case arrangement. So take your knee example. Sometimes in a planned procedure, there's enough time that takes place in the pre-auths and the approvals that the system says, oh, wait, I don't recognize this logo. I don't recognize the TPA. We should make sure we have what that reimbursement's going to be. In that situation, we engage with them and then negotiate something that is fair and reasonable. It's going to be better than you would have paid on a traditional plan. It might be a little bit more than you would have paid on a pure RBP of 140, but maybe it's at 160 or 180 or 200. But we get your care taken care of. It's fully contracted, so there's no balance billing. You're healthy again. The plan moves on and saves their dollars on all the other claims. So there's a lot of ways that we go about doing this. And I can't say that we're the only company doing this today. The whole industry, I think, has evolved and moving forward. There's some, I would put us in that category, that do it a heck of a lot better than others. But you got to have a lot of tools in your belt to navigate an entire 50 state country and get these things taken care of.
So I want to have two lines of this question. I want to talk about stats. Hey, of 100% of claims, how many of them are having any level of friction? So like back to, oh my gosh, if you talk to people, they're like, it's the noisiest thing possible. You've been running this now for over a decade. You've got your own stats and it's not anecdotal. You are the guy that has the information. Tell me the real down and dirty on the stats. Out of 100 claims, where are we having issues?
Yeah, so I would look at that two ways. Traditional RBP fear mongering focused on balance billing.
Okay.
Everyone's like, you're going to get balance billed. Now, the reality of it is traditional health plans get balance billed, all that work for claims all day long. In fact, those stats are worse than RBP stats. I remember seeing a Kaiser study. It was like some states were 30% or something.
Yeah.
I mean, it was atrocious. I think the average was 16% across the country. So balance billing in the RBP world, it has continued to come down. If you look at our book of business stats, and you're talking hundreds of thousands of lives, it is around a 99% acceptance rate on first pass. So
okay, let's pause there. Make sure everybody understands what that means. That means somebody went and sought service. The plan was billed. So the hospital, the provider, the whoever it is, build the plan. You guys are the administrator in that scenario. You took that. You said, okay, I am paying you this number. And 99% of the time, the person receiving that number, the provider of the care, says, thank you very much. We're good.
Yep. Now that is book of business. So I'm a very transparent individual here. So that includes physician and facility. Now, if you just isolated facility claims, you're probably in the 95% range, I guess 96%. So the physician acceptance is much higher. So that averages out to that 99%.
Okay, so let's just play with the 96 as the facility side. So in that example, you send the payment. Let's just pretend it was at 140% of Medicare, which if you said Medicare had an 8% margin, 40% is a bigger margin than that. So we're just, kind of defining things. They said, hey, no way, Jose. Hey, patient, your plan paid this. Here's your balance bill. You have to pay this. Now what happens? And give me the stats around that.
So the key to success here is good communication. So we need to know about it. Now, there's different TPAs that we work with that have different outreach programs that I think can be quite effective there. But once we know about that claim, then we're going to contact the provider and educate them. Here's why you were reimbursed 140%. This is why that is fair and reasonable. We're looking at all the underlying data, their financials. That first call eliminates half of that. And then after that, we begin the negotiation process. So that negotiation process is based on the assignment the plan gave us. And normally that's 140% starting point to 200% of Medicare. And then we begin negotiating until we get that thing resolved. Now, there are times where things get stuck and, nobody can agree on something fair and reasonable. And so we do have a legal solution that resolves the vast majority of those things. That it's really hard for a hospital system to stand on a pedestal and say that, even though Medicare is here, 98% acceptance rate or 96% acceptance rate is 140% of Medicare, but we deserve 1,200% of Medicare. Like, come on, who's going to go in front of a jury and justify that? Like, it's insane. So there's a lot of different arguments that get made, but the vast majority of those residual claims that don't get resolved through the negotiation process will get resolved. In fact, 99% of those get resolved with that legal MediShield solution. So it's incredibly effective at reducing the risk that a member would have from a balance bill, which again, it used to be the big fear. Now, I don't know if you're ready to pivot or not, but I would say the new front of RBP is access. That is the key to the success here, is getting people in the door for care and making sure they can continue to go in the door for care.
So set a different way for non-nerd people listening, right? That is, hey, the logo on the card isn't one of the four that I'm familiar with. I heard about this RVP thing. That logo is one of those people. No, pay patient. I know you're trying to come see us. You can't get in the door.
Yeah, just making sure that they can get their appointments. And we have a whole slew of solutions and outreach programs that take care of that. And so, I don't know if we want to get into that today or not, but the statistics on that side is, I think it's like 0.025% per member per month have an access issue. It's rare, but it's going to happen. I mean, I cannot, if you're a plan sponsor sitting on this, call right now, I can't promise you that you're not going to go that first year without an access issue. In fact, you're probably going to have access issues, and most of them are going to happen in the first 6 months as your membership goes and gets care from their, whether it's their current provider list or, maybe somebody new, that we will help eliminate that issue by calling and having that discussion with the front desk and explaining to them that this is the new plan. Here's where you're going to be reimbursed. And if they have an issue with that reimbursement, which they rarely do, because we're typically at 120% Medicare or less, that's where they're getting reimbursed anyways. But we can put a contract in place. We'll contract our way through that. And I will add to this that you're not confined to what you're used to being confined to within a network environment. You now have open access. So you can go to that pediatrician that you've always wanted to use down, across town. I was picking my family, just because they're fair game. But, my wife is a physician. She went to school. In fact, she's a pediatrician, which makes the story even funnier, but, went to school with a lady that she deemed the only pediatrician that can see our children. And before 6 degrees was big enough to do self-funding and RBP for itself, we used a local, network program here in the Northwest. So that provider, that pediatrician, was out of network for us. And I'm like, I don't want to pay out of network rates. My wife, I lose these arguments every day at home, but she's like, it's the only person qualified to see our children. So, I'm paying tons of money out of my pocket for this. Now, once we went RBP, we're not told what to do anymore. We're doing as we need to take care of our families. And so that provider is now, there is no network. So they're a part of the program. And ultimately we ended up contracting with them. And so we were able to go utilize that pediatrician. The reason this is ironic is because my wife is also a pediatrician, but somehow she doesn't know how to take care of her own kids. So,
That is, that's like, going to the RBP vendor to run y'all's house plans.
yeah, I definitely wouldn't do that. I like the way our program runs, but yeah, no, it's pretty funny.
So let's get to the to the TLDR. On the end of the day, I am an employer. I am in a traditional model. I move over to this model. I have, on average, this kind of results.
Yeah. Depending on the state you're residing, or the vast majority of your employees reside, will determine what your overall savings are. So I use savings because that's how we were conditioned to think of things. You're in California.
Mitigated costs.
Yeah. So in California, your savings are going to be more significant than if you were in Washington or Wisconsin or a state like that, just because California bills much higher than Washington. And so that allows us to save more dollars. Now, I would argue that regardless of your geographic location, RBP is going to save enough money to justify making the move. Maryland, probably the exception, just because of the way the state runs things. So we have plans in Maryland that use us for all the claims that go outside of the state. So, it can still be done. I would say on average, on average, if I'm looking at a savings analysis, so we can take any plan that is running today, look at their claim history, and show what they would have experienced on RBP. If I see anything under 25% difference, there's probably an issue in the claim set. If there's anything over 40, I'm going to say 48%, because I'll see a lot of 45%, then I know that there's also a problem. But I would say on average, you're probably looking at 35% reduction in your claim spend. And that doesn't count stop loss. So your stop loss is going to recognize these changes that you've made and give you credit for that as well.
So all in, we're looking at, let's just call it north of a 25% savings, or let's just say 25% on your second largest employer expense. And let's make sure every listener kind of, whether you're an insurance nerd or not, claims are the biggest piece of your overall cost, which lower claims dollar amounts means that the patient pays less money out of their pocket for their premium. So like everybody wins in this situation. Let's finish with this. Think of a group, and we talked about a couple of anecdotals, but think of a group that you could think of in a more, in a more mature setting. They've been doing this. They've been seeing this sustainable scenario. Hey, you squeeze because I don't want any listeners saying, hey, you squeeze the juice one time and then all of a sudden you're back to, because everyone's experienced, I moved to, XYZ carrier and then I got a 29% increase. What does this look like sustainably over the years? And give me a case study around that.
Yeah, I mean, this is going to flatten that curve. You're not going to see these big increases every year. I could probably paint like 3 different scenarios, because you can use RVP in different ways. So you can use it as a full replacement, and I give you an example of that. I've got others that build kind of a narrow network, a contracting model with RVP capture and everything else. Down in Texas, we've got, several different firefighter groups that, they live in a market where they actually had their own contracts to begin with, and they're fine to continue to use those. They didn't want to make the full leap to RVP. And so what we do is pick up every claim that falls outside of, their handful of direct contracts. It's a phenomenal relationship. The membership are happy. They continue to grow. It gives them a recruiting mechanism because they can keep their healthcare down. It helps protect their fund, and they don't see the disruption simply because they're mainly, they're running contracts. And so that access issue that I mentioned earlier is pretty much eliminated. I gave the example of the guy that jumped on my back almost on the beach. That's a phenomenal story because they had an advisor that never presented RVP to them. It was one of the bigger advisory groups that are out there, and they're incentivized by the bukas to keep them right where they're at. And they had an employee that had a claim, and that employee happened to have a husband that was kind of one of these independent brokers, and had heard and met 6 degrees. And he said, hey, let's take our claims. So it was their own claims. They had some pretty catastrophic things that had happened. And let's have 6 degrees run it and show the employer what they would have done if they'd been an RBP. And they were pissed. That C-suite was like, why has nobody ever mentioned to us what RBP could do for us? And they fired their big house broker, moved it over to this independent. And, I think they've been with us for 6 years now, but millions of dollars every year savings that they're putting back into the employee plan. That's out in the Midwest, a transaction company, a financial transaction company. And it's changed the company. And then there's another one up in the Northwest where it's a manufacturing company, but they were in a single provider town, which a lot of people say, well, what if I'm in a small rural area? Could you even get away with this? And the answer is yes, because under our model, we have the ability to pivot to a contract system. You create your own network. And a lot of their employees were traveling to the city to get care because their network discount was so poor at their local hospital. So the hospital in that town was losing out on surgeries and planned procedures. They were going to the big city. What we did was work with everybody involved and said, hey, let's keep the membership here. Let's drive volume to you, provider, but we need something that we can all work with. And then once that agreement was in place, we can then RVP everything else. So now the incentive is to stay local. So it's helped the local manufacturer, it's helped the local provider, it's helped the members. They're not driving 3 hours to go get care. And it's a phenomenal story. And those things, because of our ability to pivot based on the risk tolerance or the needs of a plan, that story will change wherever you go. But there's not a one size fit all. It's what's best for this plan and how do we execute it. And we'll work with you, the advisor will work with you, the plan. We'll work with the vendor stack to come up with that solution. We basically become the chassis that you build everything on.
Awesome. Awesome. Heath, I want to make sure that if somebody heard this and they're like, hey, that savings analysis sounds amazing. I want to learn more. Where does somebody, follow you, follow 6 Degrees and learn more?
Well, I'm probably on LinkedIn somewhere. I am the worst at that. I got to get better. So you can find me on LinkedIn, or you can email me at Heath, Heath, Potter, Potter at 6degreeshealth.com, number 6degreeshealth.com. I'm probably on our website as well, I'm guessing. I don't know if you go to 6degreeshealth.com, I'm sure I'm on there somewhere. And then a lot of you probably know my director of growth, Melissa Williams. I think she's been quite the celebrity, but she's always a resource as well. So
Awesome. Awesome. And would it be okay? This is impromptu. You threw it out there. Can we offer anybody who's listening to this an opportunity to get that savings analysis?
yeah, happy to do it. I know you're probably just kicking tires, but I think you'll be impressed with what the savings can generate. A couple things to think about. One, is your local or is your current carrier or network willing to give you the claim data? So that's the first thing. If not, if you have kind of a population distribution you can share with me, I can give you some averages. But if you can give me the claims, by all means, we can run that thing, show you exactly how it stacks up in that time frame for doing reference space versus what you're currently doing.
Awesome. Awesome. Well, Heath, thank you so much for being on the Dysrupt podcast. If you had to leave the audience, and I'm going to say, talk to an employer, right? Because that's the person that, it drives me bonkers when people call the carriers the payers, because last time I checked, they're not using their own money. So let's talk to an employer out there. If you had one thing to leave the employer with, what's the one thing you leave them with?
Yeah. I know that you're getting your door knocked on all the time with people promising you savings. Um, some of those are soft. Those are really hard to calculate. This is the real deal. You will see a significant cut in what your claim spend would have been. let's say 35%. Those are real dollars you can create a fund with, dollars you can put back into paychecks. The program works. And we're going to work with you to make sure it works. But that's what I'd say. If this isn't smoke and mirrors, it's real dollars.
Awesome. Heath, thanks for the time, man. Thanks for doing this early. I mean, I always think that I'm a pretty OG in this space, but I started way later than you. So thanks for leading the charge, and thanks for being somebody that isn't scared to disrupt.
Yeah. Well, thank you. Cause you got the voice, man. You're out there pounding the drum. So I appreciate it.
Awesome. Thanks, man. Thank you to the audience.
Take care, everybody.
To everybody listening. If you like this episode, hit share, hit like, leave some comments. The only way, we grow, but the only way we're truly going to create a disruption is by educating more people. So thanks a lot.